Well, thank you very much, Peter, for the invitation. Also, the very nice words. I won't talk in German. I can understand you, but my German is that bad that I won't bother you with that. I want to talk about evidence-based spine surgery, and not only surgery, also the probability of conservative treatment, a little bit of my history, the current and the future. And I'm very glad that I'm here in Berlin to talk about it, because my first spine congress was Eurospine in Berlin. In the past, I'm a neurosurgeon from origin, and I was in the past mostly doing vascular and skull-based surgery. And only because I started to do cranial cervical tumor surgery, that was the reason why I went to Eurospine in Berlin. And currently, I'm most of my time doing spine surgery in the clinics. I have quite a few conflicts of interest. The most important one is the Brain and Spine Journal. I'm also here to let you all publish in that journal or read it. But also have some commercial interest. But the commercial interest is mostly investigator-initiated studies. So only studies in which we designed the research question and also the outcome research. And last but not least, I'm also chairing a department in several hospitals in which that's also interest. So if we stop with doing surgery, the inflow of budget to our departments is also less. Most people won't say that is a conflict of interest, but I think it is. And this morning in the bus from the hotel to here, one of my old colleagues, which I didn't see for years, said to me, "Well, Wilco, are you telling us not to operate?" Well, we have to stay operating because patients need our care. So why evidence-based spine surgery? Why epidemiology? Well, I think we need to move from this gypsy foretelling, which we do as orthopedic and neurosurgeons, telling what the outcome of the patient is, while we don't know. So why should you tell something about the proportion of effective surgery if you don't know what the outcome is? If you don't know the real complication rate you get to your patients. So that's the reason why we need some mathematics. And I know that a lot of people think that mathematics and statistics are borrowing and terrible. Well, it's very nice. The working on it is difficult, but when you open up your database and you do your analysis and you see the result, that is very satisfying. Very satisfying to see studies being resulted in good or bad outcomes. So we talk about the past, the present and the future. Some people, also in this room and probably also outside, were not very happy when we published this paper in the Lancet series about low back pain. I received some messages, Wilco, why was you co-authoring this Lancet paper about low back pain? Because most of this Lancet paper is about non-specific low back pain. But then the question comes, what is non-specific? Was the research being performed until the 90s of last centuries good enough to say that? Most people only look at treatment. If you're an orthopedic or a neurosurgeon or a physiotherapist, you look at treatment, but you forget to look at the first paper in the Lancet paper, and that is about epidemiology and also costs. And what you can see that in 1990, and also recently in 2013, low back pain is #1 in healthcare expenditure and also in loss from work, absence from work. And low back pain and depression are the two most money-eating diseases, if you can talk about a disease in low back pain. What should we do as a spine community to that? And you have a huge community. I was impressed by this, my first time at the DWG. You are a big community. What can we do about it? Well, if you look at the specific causes of low back pain, including neurological complaints, these are all not very well studied. Not in pathophysiology, not in treatment. So for instance, most of my work, daily work, is trauma, tumor, deformity, especially degenerative deformity. But why don't we study that thoroughly? Yes, we do case series, but if you have a new intervention, why shouldn't you compare it to another intervention and work together with researchers who can do that? So we have work to do for the next few years. When I started research, and I saw some people from the past, I was curious. And in 25 years ago, there were some guys like Ulf and Ralph, who were called the spine stars, something like that. It was invented by industry. The only thing, I think, we were invited to sell a lot of products. But at that moment, we were very young and curious, and I wanted to do research. And my main curiosity, what am I doing? So I was trained in a center where they did a lot of low back surgery, very aggressive disc removal for a herniated disc. And when I asked as a trainee, what's the effect of that? Can you destabilize the patient? The only remark is, you are a trainee and you have to listen. The old-fashioned way of leadership. And I was curious, and I wanted to do research. And when I went to my boss, my chair of my department, I said, I don't want to do research in rats, but I want to do epidemiological research. He said, no, Wilco, don't go away, that's for sissies. Really, and he's a very good surgeon, I still like him. But he said, Wilco, if you're doing research, it's soft outcome, and that's not for a neurosurgeon. So I went on doing research, a lot of clinical work. And then I went on holiday with my small kids and my wife to Switzerland, and I saw this painting. And until that time, I was hardcore surgeon, only doing surgery. And when I did research, it was mathematics and quite the hard way. And when I saw this painting in Val Sinestra, I said, why did I become a neurosurgeon and a spine surgeon? Well, I wanted to look after my patients. And at that time, I didn't look anymore at the outcomes of my patients. So that was my personal paradigm shift. Do we really care about the outcomes? And those outcomes might be soft and difficult to measure, but they have very hard consequences for our patients and society. So starting thinking about that, I thought about my trainee period, what I just told about sciatica and lumbar disc surgery. Did we do a good job? And here you see one of the three ageless women having sciatica. And this lady is very interesting. When I did a systematic review, I also looked in history. This lady, her bust is here in Berlin, but she was living in Firenze years ago, and she was the first good described sciatica patient. Described by Domenico Cortigno. And you have to imagine that in that time, sciatica was treated by sticking a hot needle in the sciatic nerve. So sticking a hot needle in the sciatic nerve, well, you can imagine that the patient at that time favored conservative treatment. So she was treated conservatively, and she had a good result. So already for centuries, we do know that sciatica can have a good result. So the only thing we did was a comparative effective research by an RCT. And most of you know the results of this trial. Early surgery is effective for early recovery. But longer wait and see, like they do in the United Kingdom, gives also a good result. But it takes longer. And the patient might decide. So you can let the patient decide. And depending on which part of the world you are, there's a different interpretation of our results. Nearly the same results were performed by the sports trial in the United States. In the United States, they say, well, it was proven that surgery is effective. And you see these kind of papers in the States. Can you play football with repaired herniated disc? what is told here is that they say, well, you have to do surgery if a disc is herniated in an American football player. Well, I would say, can you play football with conservatively treated herniated lumbar discs? Not always if you are in a lot of pain, but we have football players, also of our Dutch team, having had sciatica and not treated by surgery. And we know that surgery is effective, but depending what the outcome is. So I think that for sciatica, you might be a little bit too aggressive if you operate after 6 weeks, and probably have to operate after 3 months of natural course. Recently, by the Canadian people, Chris Bailey did the same trial, but after a longer period of wait and see. And what did he show? That all the results were more effective for surgery at that period. So his conclusion, after all the studies being done, and probably not that many studies will be done anymore, is that surgery is more effective after 4 months wait and see, after 4 months natural course. But again, if the patient has a lot of pain at 2 months or 6 weeks and has a job being a spine surgeon or a football player who cannot do his or her work, well, the patient can decide. It's not a mistake to operate upon early. It's only you have to inform the patient about these graphs. Show that to them. Going back to my training time, this is the way, on the left side, you see how surgery was performed. I don't see that. So I did a complete laminectomy, so I was trained. And we did a lot of that kind of surgery, destabilizing the back. And one of the first PhD theses at that time of one of my trainers was called the weak back. And not the weak back because of non-surgical treatment, but weak back because of surgical treatment. And what did they do? They did a complete laminectomy. And I was trained with that, although I'm from this current generation. And when I presented during a study in the Netherlands, the study by Claudius Tomé, that you can also have another approach, do it less invasive, appropriate invasive, then they said, well, that's a selection of patients. So surgeons, we as surgeons, always try to defend what we are thinking. And even if proof is there for otherwise, they still proceed with old-fashioned surgery. So we know that for spinal stenosis surgery, you don't have to do a complete laminectomy. Still, some hospitals, even in my country, Netherlands, are doing a wide laminectomy because they believe in it. So they don't implement the new evidence and even don't read it. Very selective reading. And that should be stopped. So after the first sciatica trial, we did the microtube study, microendoscopic surgery, and I was very much in favor of that. So we did microtube study and in small hernia disc, the laser surgery, compared to microdiscectomy. And in contrast to what we thought was effective, we didn't show any effect. So it was not better than a normal microdiscectomy, as described by Kaspar. And that was disappointing, because we thought we had something effective. But it was effective, but not better, not more cost-effective. That might be different with the transforaminal approach, but we have to look into data. I know there's a lot of discussion about this trial. I won't present it here, but the 2-year results will be analyzed in 1 year. And then, if we do a study in Germany, in the Netherlands, in the UK, in North America, are these spines the same spines in our trials as elsewhere in the world? So when I operate upon patients in South America, they have different spines, different bone density. And the same is true for Asia and Africa. So we have to look into detail what's happening globally and also look at frequency. And in the background you see the global world, and that there is a high incidence of degenerative spine surgery in our countries, and less, as you expect, in South America and Africa and parts of Asia. If you have the same chart of the WHO for trauma, you see it the other way around. So what to do about that? Well, we know that a lot of publications are about less effective treatment. Are we treating the right patients? Are we doing the right thing? So this was published in the BMG, and you see that more than 50%, there's no research in it. And people in the politics in my country, in the UK, and I don't know about Germany, they think we are doing a bad thing. And they want to discuss that with us. So there's a real political discussion, not as harsh in the Netherlands as in the UK. In the UK, it's quite harsh now. So if it's not effective, you are not allowed to do it. But we have to be aware of that, and we have to be a counterpart. As spine surgery societies, we have to be a counterpart and know your data, know the real big data. Because a pediatric case like this, with spinal cord threatening disease, needs to be reconstructed. But do we have evidence? No, we never will have an RCT for that. And the other way around, if you have a degenerative scoliotic deformity and the patient on an old age only has low back pain, we do know that there are high risks for treating low back pain in those patients. And that's also published in the JAMA by the group of Rick Dio. So if you put those different diseases in the graph of the BMG, you will see that for spinal met disease and primary tumors, there is some evidence of added value. So only 34% of our treatments, all surgeries are proven to be effective. Only 8% is shown to be ineffective. So surgery for 3 black discs, for instance. But more than 50% of our treatments, there's no research. What the politician will say, or the health economist will say, if there's no proven added value, you are not allowed to treat. That's the other way around. So we have to work on treating these patients. And we are there for our patients. And sometimes we have a bad name, failed back surgery. There's no other disease with a syndrome caused by surgery. So when we go for implementation of best practices, we all know these graphs of management training and MBA training. You get this, the CASM, the early adopters. So we have to work on implementation of best practice. And I emphasize we are here for healthcare and not for health commercial. We need health commercial companies, but we are there for the healthcare part. So we have to debate that. So we know some best practices, but sometimes there's a best practice already implanted, like the Coflex, while there's no evidence for that. A lot of money is being earned by implanting Coflexes while there's no evidence. And this is a study of one of my old PhD students. He's still young, Wouter Mooijen. And you see the marketing, the Coflex like a golden, shittering and shining future treatment of elderly patients for spinal stenosis. Well, it might help in decompression and added fusion to hopefully have less back pain after surgery. But if you compare Coflex to just decompression for spinal stenosis complaints, it is not effective and in no way cost effective. There is, however, some future of these kind of implants instead of using pedicle screws. And one of the studies did show that. But to treat all patients worldwide with an IPD instead of a simple decompression is way too far and not good. So where do we want to go? Where do we need to go? Well, we have to look at these diseases, the elderly, the spinal metastatic disease, osteoporotic fractures. Is that easy? No, it's not easy. Not all my studies were successful. Here you see a study in which we try to compare decompression with conservative treatment in the elderly. It didn't work out. It cost me a lot of gray hairs, a lot of worries, and we couldn't randomize. And it's a lot of waste of money. So, what to do now? What's next? These studies are published, and how to react with that. For instance, degenerative spinal stenosis with olisthesis. We know the Swedish study, which was good. There's a North American study, which is good. And the end result is, if you do decompression in a stable olisthesis, without a nerve frame problem, you don't have to fuse. Probably my language was not good, because I called it a safeguard or a superfluous surgical implant. And that created some worries among the spine surgeons in North America. But how to proceed? What should we do? What should we do, and what should you as young people do for the next decades? This morning, Professor Ames already said, we need big data and how to work with big data. So we have to treat those patients, but how to evaluate the outcomes? Do we need surgery, and compare that to conservative care? If a patient is able to walk and walk bended beforehand, why do we want to have a PSO? But if the patient has neurological complaints, then you need a PSO. But how to compare that? How to do that? And this case, a pediatric chordoma, we don't do an RCT for that. So when you asked me 20 years ago, when I was trained in epidemiology, what do you want for study to prove what you want? I said, always an RCT. RCT, I was really only on RCT. So you have a sample size, you do your RCT, you show that something is effective, and then you go to the worldwide population and show the results. The latter thing we never did do very well. And we know the diseases where we talk about during this Congress, spine tumors, deformity, trauma, are we able to randomize those patients? No, we are not. And currently I'm doing a lot of brain trauma research in Europe, also in Germany. And we know that we can do research without randomizing, but with a very good data registry. And not a simple data registry based on your DWG system or our Dutch DBC system, but outcome prediction modeling. And one of the most important things is one of the keynote speakers who spoke yesterday, Michael Felix, did with early surgery versus delayed surgery in spinal cord injury. Very good study. I know that there are a lot of remarks, but now we know that early surgery is effective in spinal cord injury. And probably ultra early surgery within 8 hours is even more effective. Was this randomized? No. So what you do is CER, comparative effectiveness research. That means that you use the practice variation throughout Europe or within your country. You have a huge country and there's practice variation. People in Hamburg are treated in other manner than in Münster or in München. You keep it that way. You don't do an experiment. You measure the data like it is an RCT. So you use this practice variation and then you go back to your sample size. It's very difficult mathematics, so you need people who know how to calculate that. And then you can use this as a kind of surrogate RCT. So what we are now in, we are doing clinical research and we go to health service research. So that means that we have to work together with insurance companies, with big data file specialists to go for that. So the future for our difficult pathologies in spine lies in observational studies. So there's a difference between efficacy, so doing the RCTs we do until now and still do is necessary before you implement in daily practice. Then you look after your RCT, is it working in my patients? Effectiveness. And in the end, economic evaluations like Michael Porter's added value. This is the way to go. So I think that the big data, if measured good, are real-world data. But then the good data have to be measured and encrypted very good in the database. And some diseases don't need an RCT anymore. So what to do for the next period? And I'm very much looking at the young generation of surgeon scientists. If medical ethically you can do a randomization, you should do it. Because that's the most effective way to eliminate confounding. But for kyphotic deformity, oncology and trauma, I would say we have to go to CER. To help you remember, the study of Peul in spinal mat disease took 10 years to include a very small sample of patients. We could have done better by comparative effective research. So these are the scientific challenges for the next period. What do we want to do? Primary bone tumors. Why shouldn't we, as European centers in primary bone tumors, which is a rare disease, compare our outcomes and do also epigenetic research? And what about juxtamedullary tumors? Every neurosurgeon, some orthopedic surgeons do juxtamedullary tumors, but we don't look at outcomes. And everybody is doing a different way. There are even legal cases about patients operated by a hemilaminectomy for juxtamedullary tumor, because another expert said, well, a hemilaminectomy is a mistake. Well, it is a normal practice in a very big area of Europe. And the same is true for skeletal balance and timing of spinal cord injury. So this time is over. Scientific leadership telling me what to do, to the young people what to do, that's over, that's history. In the future, it's time for the young surgeon scientists to look for bottom-up. The curiosity to be evaluated. For instance, virtual reality. I'm still feeling young, but I'm nearly 60, so I won't be a very good virtual reality surgeon. I won't be a very good robotic surgeon. I don't like it even. I know that it might have future. But the young generation wants to implement that. But again, we have to evaluate that. So that's a challenge. So in my final slides, I want to end what somebody said more than 100 years ago. Emery Codman, you all know the name, orthopedic surgeon, working together with neurosurgeon Harvey Cushing. And he said, well, we as surgeons, we need to compare our results, our outcomes and our complications, and act on that. And he called it the end result hospital. Well, this hospital, and especially this cartoon, costed his career. So he was finished as an orthopedic surgeon because he told the people to compare the results. And we are now more than 100 years on a row, and we still are not able to compare our results between hospitals. Economists do it, but we have to do that ourselves. So finally, again, some marketing for brain and spine. I hope that you read, write and submit publications, not only to brain and spine, but also to the high impact journals. Thank you very much.